Good evening, everyone. It's a great honor to have such a wonderful panel from the American Head and Neck Endocrine Surgery section. The topic tonight is going to be locally advanced thyroid cancer. We wanted to offer the opportunity once again to have anyone join the endocrine section of the American Head and Neck Society. On our website is the access information and the information for becoming a member. All are certainly welcome. And there will be CME for this webinar. Disclosures have been given by the panelists, and Dr. Marika Russell from the University of California, San Francisco is going to introduce our panelists for this evening.
Great, thanks, Joe. So we're really excited to have such an esteemed group with us here tonight. Joe from Cleveland Clinic and I from UCSF will be moderating. We have Dr. Rich Wong from Memorial Sloan Kettering and Dr. Greg Randolph from Harvard Mass Eye, who will be our discussants. They will be the experts to whom we will be asking questions. All of our panelists tonight are experts, but Rich and Greg will be serving in that role. And then we'll have 3 case presentations, the first by Dr. Amy Chen from Emory, the second by Dr. Mark Zafario from MD Anderson, and then Dr. Maisie Shindo from OHSU will be sharing the third case. And as we go through these cases, we'll be having an iterative discussion, asking our discussants to share their expertise, how they might approach these cases themselves. And at any point, if you have a question, please do enter it into the chat. We welcome those questions and we'll try to get to them as we can. So without much ado, we'll get started. If Amy, you want to go ahead and share your slides?
Okay, very good. Thank you to the endocrine section for this invitation to present. I'm going to be talking about preoperative workup and some of the different nuances that can take place in such a patient. So my case is a 28-year-old female who presented with a 4 to 5 month history of a right posterior neck mass. She discovered this when she was pregnant, and she was about halfway through her pregnancy when she noted this. Her doctors told her to wait on the workup, so she had no workup at all, no ultrasound, no biopsy, nothing. And it was delayed until after the delivery of her infant. So we saw her when her baby was about 4 weeks old. A CT neck was performed on the outside and before she came to us, and the outside differential included a schwannoma or a cystic lymph node, and that's taken directly from the written report of the outside films. She had no past medical history, and her past surgical history was none. She was very healthy.
Okay, maybe before you go on, we'll ask a couple of questions for Dr. Randolph and Dr. Wong. Had you seen this patient in your clinic, what's something you might have considered doing if you were worried about getting a CT during pregnancy? Is there something else you might have considered doing for this patient during her pregnancy rather than delaying her initial workup? Dr. Randolph, perhaps?
Dr. Wong.
Dr. Wong.
First of all, I just want to say thank you so much, Marika and Joe, for the honor of participating. This is really exciting for me, and it's such a great panel we have. I also feel like anyone should feel free to jump in with comments because there's such deep expertise across the board here, and I'm sure you want to hear from more people than just me and Greg. But so I guess the first point here is you're asking about alternative ways to image. Of course, when someone's pregnant, we want to avoid any ionizing radiation, and so one easy thing to do in the office would just to look at it with an ultrasound. It gives you a great survey of the entire neck, and you can look at the thyroid at the same time. It's just sound waves. It's completely innocuous, and you can also do needle aspiration biopsy in the office very easily to get at the crux of the diagnosis here. So I agree that I probably wouldn't rush to CT scan in a pregnant patient. The other thing that's kind of interesting is this outside report where they're including schwannoma in the differential. Obviously, both schwannomas and lymph nodes can be cystic, but they have such different characteristics. You know, schwannomas typically are more fusiform, and they're in the anatomic distribution of a nerve. They have particular characteristics structurally. Also on MRI, they're typically T2 bright if you get an MRI instead of a CT. So this is usually not a differential diagnosis that is, we don't see these two diagnoses usually competing with each other. Those are my thoughts, and I think it's a little bit unusual. Interested to hear what Greg thinks.
Yeah, thank you, Rich. I agree. First, I do want to thank Joe and Marika for putting all the effort in putting this together, and Monica, the head and neck staffer, for putting everything together, and Mike Singer and Brendan Stack, the chair and vice chair of the endocrine section, for getting us all together. It's an honor for me to be part of this panel, and also it's very enjoyable to me that we're all such good friends and enjoy working together, and it's nice to have such renowned friends as is on this panel. This is a really, I think this whole case that Amy is presenting, it's no mistake that Amy is presenting this, because it keys in on a key issue of preoperative evaluation. I think, when you're dealing with thyroid cancer, especially advanced cancer, it's really not rocket science. You just have to pay attention and do your homework and think a little bit. And so, I think a lot of the deep weeds can be anticipated with an appropriate, thoughtful preoperative evaluation. I agree with Rich that ultrasound would be an important adjunct to this that could be safely applied during pregnancy. The CT scan is interesting. I've had nodes that are cystic or vascular, very well vascularized, read on outside imaging as glomus tumors or schwannomas. And so to get the CT on a CD and have your radiologist read it after they've done the ultrasound, so that they can go back and forth and cheat, and look at the CAT scan and then go to the ultrasound and use both at the same time. So I would make an appointment for an ultrasound in radiology with this patient and have them get the CD and give it to the radiologist before they started the ultrasound, so that they could use both.
Great. Okay, Amy, you want to continue?
Okay. Her labs, she had a normal TSH, and then I can show the CT. Do you want me to show the CT first?
Sure.
Okay. So on physical exam, she has bulky right-sided cervical lymph nodes and bilateral vocal fold movement. Really nothing you could feel in her central neck. So this is her axial CT scan, and I'll show you the coronal in just a minute. So this mass back here is what she was feeling, and that's what they were calling a schwannoma. And then she has some other lymph nodes here in that central compartment.
So you've mentioned some of the other studies that were done, but maybe we can get some thoughts before that discussion on the imaging here. And
yeah, I thought we'd talk about imaging, and then I can go back and
sure. Greg, and
then I can show you the coronals real fast if you'd like.
Yeah.
So there's another big lymph node. There's that one up there.
So Greg and Rich, what do you make of that imaging by itself there?
I like to make lists in my impression plan of thoughts that I have when I look at things as I go through the history and physical exam and lab work and radiology. So the notes I would make with that CAT scan, if you want to just run it through again, Amy, that would be cool.
Oh, sorry. Go back.
Is the upper node, maybe you
I
could
can
just
pause
stop.
it if you need
Yeah,
me
that
to,
would be
Greg.
great. Yeah, when you get to it, you could stop it. So this is pretty high. So
Oh,
the first
what
thing
happened?
I'm thinking of with a high node like that is, first of all, this node is a little unusual in that it's fairly isolated and it's up high. And so that makes me think, is there something else anomalous here? I would look carefully for retropharyngeal nodes, because there's something tracking up high, and I would just make note of that. In terms of the management of this node itself, this is something where I normally do my lateral neck dissections through the thyroid incision by opening up the incision. And so this would be where sometimes you can do that and sometimes you can't do that when a node is this high, because this is a 2B node, it looks to me. And so spinal accessory is going to be splayed all over this. So I would start to be talking about spinal accessory and maybe a second incision, maybe a higher incision that's wider so that you can kind of, so like when a node like this is a recurrent node, I don't access it through the former thyroidectomy incision. I do a wide submandibular gland incision so you can get right onto it. So I would be thinking about that. It depends on how long the patient's neck is as to whether you could get it in a slightly higher but wide standard thyroid neck dissection incision. And then the other node lower down is a retrocarotid nodes, and we all have, I'm interested in Rich and everyone's thought as to whether you classify that as a central neck node or a lateral neck node. You can, I think, mainly just don't be too dogmatic about any one label because you could make a good argument for either. But whichever category you put it in, you have to start to also be thinking about sympathetic chain and phrenic nerve, because this is like a very dorsally located dorsal in the dorsal element of the carotid sheath area. So, cautery around its edge can end up giving you a Horner's, even when you're being careful. So those would be some of the things technically I would be thinking about.
Okay.
I might also add that you can see that there's a lesion in the right thyroid lobe. It's not well defined, but that's probably your primary. And I liked Greg's comments about the spinal accessory. When the 2B node is bulky, you have to be thinking about, to be very careful about the spinal accessory because the node could be behind it, or the nerve could even be, bowed over it. So you have to be very careful there. With the neck incision, you definitely need to have a low incision because this is a heavy set neck. There's a lot of distance from the skin to that retrocarotid node. So it has to be low, but it has to go up high. So I don't mind doing like a U-shaped incision, or like whatever, a hockey stick, or a half U to get really good high exposure and to get good low exposure. I try to avoid the double incisions, but a lot of people do that, and there's nothing wrong with it. I just prefer one incision. And then there's a lot of nodes there, so you need to book this for more time than a regular just quick thyroid neck. You have to be really meticulous. That retrocarotid node is really important, and that's a frequent miss. If you just do a fast neck dissection, you're not careful, you could leave that behind.
This is also Amy's wisdom of getting the neck CAT scan, because that's the sort of node that you could do a thorough right lateral neck dissection and a fairly thorough ipsilateral right central neck dissection and not see that node. You'd have to dissect all of the structures and go deep to the sheath inferiorly. And if you didn't really have any reason to do that, you could easily miss it. You won't now because your CAT scan has shown you this is one of the targets you need to achieve. But
Yeah, all very, very good points. Amy, do you want to, we're just a few minutes left in your presentation. It seems.
Yeah, so just to, she did have an FNA, and the first FNA she had was not ultrasound guided. Someone just kind of grabbed it and poked a needle at it. And the pathology was atypical cells, primarily cystic, but the TG wash was quite high. So I guess one question I would have is this sufficient for you guys to think that it's thyroid cancer, remembering that her thyroid is intact, or would you re-biopsy her under ultrasound guidance to make the diagnosis first?
Dr. Wong?
Yeah, I think it's diagnostic. I love your point, Amy, about how someone just poked a needle into it. And I think with ultrasound, the ultrasonographer can target the solid component of the lesion, not just the liquid component, and have a higher diagnostic accuracy. It's also not wrong to look at the thyroid carefully and to consider biopsying the primary site also if there's any ambiguity or any indecision. And there's so many nodal targets that you could easily pick a different target and get it. If you have a patient who's just wants to get on with it, it's fine to consider this diagnostic. If you've got a lawyer patient who wants it really ironclad and you want to see papillary thyroid cancer in there before you do this big surgery, then just repeat it. It's so easy to do.
I would say it's more of a conundrum when your TG is like 30, 20, or 16. Maisie?
Is there an image of the node by any chance somewhere?
An ultrasound image?
Yeah.
I don't have it on the presentation.
So the only thing I would have to add to that is if you have classic findings on your lymph node of the punctate echogenic foci, and you got a TG that elevated, it's most certainly that. However, you got to be a little careful in young people with level 2 nodes that have punctate echogenic foci, because they could be branchial cleft cysts. But if you've got a level 4 or, some node down there that's got, all those classic ultrasound findings, I don't repeat the FNA. I mean,
I've had a thyroid vessel duct cyst with a TG of like 13, and I
Right.
was on the horns of that dilemma that I was just describing. So
right. So that's a little bit different than like, a level 3 node or something. But so sometimes I use the
different than like a
ultrasound.
TG of 10,000, like you're square there, I think.
The other thing you can do too is at the outset of the case, just send one of those notes for a frozen as it's beginning, and you could confirm, through that vector too.
So all good discussion. What we elected to do was biopsy a different node, and it was positive for PTC. And so when she came to us, she already had that, poke FNA. So when she saw us, we did the ultrasound, saw this lesion, just like what Dr. Wong said, there's something in the right thyroid. And we re-biopsy one of the lower, more solid level 4 lymph nodes, was positive for thyroid cancer. So I think we've talked about many of these things. So I guess my last question is about surgical planning. Obviously, she needs a total thyroidectomy, central node dissection, and a right neck dissection with a little bit of a posterolateral thing going on with that level 2B. But there's nothing on the left side. So would anyone dissect the left side? And does anyone have any particular order in which they do these top 3 things? Like, do you do the right side first and then the left side, or you start on the left side and you do the right side, you start with the neck and then do the thyroid? Throw that out.
I don't have a strong opinion on the order. I would plan for a right neck dissection, a total thyroidectomy, at a minimum, a right central nodal dissection. And the left central, I decide based on scrutinizing the imaging and at the time of the surgery. I don't automatically do every bilateral central nodal dissection. I separate the central into right and left. In terms of the order, I think it's dealer's choice. The one advantage to doing the lateral neck first is that, first of all, you're doing kind of the hard stuff first when you're fresh, because I think that bulky stuff is a little tricky. The second is that it's nice to have the vagus out and making sure you have you can easily get a positive stimulation to make sure your system is working before you go to the central neck. So that's just one thought, but I think you could do it any sequence that you're comfortable with.
I do like starting with the neck first. I think spatially open things up so that the central neck is a downhill slide, and a vagal stimulation in your back pocket is nice to move to the central neck. Also, when you have a case that's advanced like this, it's only advanced nodal wise, but it could be advanced invasive wise when you get to the central neck. So you can dissect out the ansa-hypoglossai to use as an Arlen anastomosis in the case that you might need it. These are all things that come from the neck first approach.
There's a question of what the diagnosis was, and I'm sorry, I skipped over that. It was papillary thyroid cancer.
All right, great.
All
Well,
right.
great discussion. Thank you, Amy. I know you have to drop off. So I
Thank
think
you,
we'll
Amy.
move on, yeah,
Nice case.
to our next case. Dr. Safari, if you want to share your slides.
Can you see these slides?
Yep.
Hear me okay? All right. So thanks again. It's an honor to be here with such renowned panelists and discussants. And thanks, Marika and Joe, for organizing and moderating, and Monica for the administrative support. So disclosures, I do have research funding, clinical trials from Merck and Eli Lilly. So this is a medullary thyroid cancer, local regionally advanced medullary thyroid cancer. We'll present a little bit and then ask some questions. So 31-year-old local regionally advanced and distant metastatic sporadic RET mutated, it's a 918 mutation medullary cancer, has some scattered small lung nodules, which are likely metastasis, although sub-centimeter, otherwise no structural distant disease, has a fairly high calcitonin of over 70,000 and a CEA of 366. Some mild hoarseness, and you do a laryngoscopy, and there's a little bit of, the cord is mobile on the right, but there's a little bit of asymmetric decreased movement on the right when you compare it to the left. And here's some images. These are from October of this year. So starting with, we'll start from the mediastinum. I didn't have the video that Amy did. I should have done that, and that maybe would have been a more efficient approach here, but I put some still pictures in here. So this is on the left is mediastinal disease. You can see this is the innominate vein on the left side. You can't really see on this picture, but you can see the jug coming down to the innominate on the right. You see this mediastinal node wedged in here. And you see on
Mark, is that infiltrating the superior vena cava there, or is it discrete from it?
Unclear
Yeah,
from the imaging. Yeah, so it's certainly a question. And so, yeah, and so when you look at the axial imaging, you see here's the innominate vein, and then on the you can see the right innominate vein here, and you see the disease here. And yes, it's the wall of that vein, unclear if that may be involved with the disease. Here's the disease in the thyroid bed. So of course, some extrathecal extension into the right tracheoesophageal groove. There's also some pretty bulky nodal disease, both sides actually, and you can see it's sort of this sort of ill-defined nodal disease with some extranodal extension. The jugular vein is fairly compressed here. It may or may not be, the wall itself may or may not be involved, but it's definitely been pretty compressed by the disease. And there's a retropharyngeal node up high on the right. You can see the styloid here. This is at the level of the maxilla, and there's a sort of a retropharyngeal node. And again, it's not one of these really nicely defined retropharyngeal nodes. It's got some kind of irregular borders to it. So that's the baseline disease. We treated this patient with neoadjuvant selpercatinib. We do have a clinical trial for this for 6 months. This selpercatinib, of course, being a RET inhibitor, this being a RET mutated medullary thyroid cancer. His mild hoarseness did actually improve a little bit during that. His calcitonin dropped as we would typically expect, from 71K to 3.5K, and CEA similarly 366 to 92. And then if we look a little bit in terms of his imaging response, there was overall, I'd say, about a 30% response of disease. You can see some disease response, and again, this is over about a 6-month period. You can see, the margin of this trachea is perhaps a little bit more well-defined now on the right image. So that gives you maybe some comfort that in terms of the involvement of that tracheal wall. Again, you can't see the nerve on the imaging, but the disease is a bit smaller. So we think that could potentially help us in terms of the dissection of that right recurrent laryngeal nerve. The mediastinal disease, a little bit smaller. Again, I still can't say from this imaging whether, and again, this is just one shot, but even scrolling through, and I'll go, this is the coronal, and we'll go to the axial. It's the disease is definitely smaller. You see it measured 28 millimeters here, and in the same plane, it's now 19 millimeters. So it's definitely smaller, but still the interface with the wall of the innominate vein, sort of at this junction of the left and right innominate veins, is still a little bit murky there. And this retropharyngeal node is also much smaller. It's probably about half the size, but it does sort of beg the question now. You got this really, really tiny retropharyngeal node, which is high up, close to the, here's the styloid, here's the maxilla. So it's not a real low retropharyngeal node. It's not at the skull base, but begs the question of what to do with that lymph node. And then this is the neck disease. You can see that on the left is the pre-treatment, and on the right is the post-treatment. And you can see the jugular vein is much more well-defined now. Still got looks like some extranodal disease here, but the jugular vein being much more well-defined here than it was significantly compressed here by the disease. So we, this talk is really to focus on intraoperative. So moving straight to the intraoperative pictures, and I just to insert a little bit of humor into this. So as I was cutting and pasting this image onto this slide today, I got this artificial intelligence alt text that says automatically, I don't know if any of you have seen this with I guess it's through, I think this is through Google, but it says this is a picture containing pizza sliced pizza. So I was a little bit offended that was the artificial intelligence description of the surgery. But so the
Mark, if it
patients,
makes you feel any better, my phone categorizes my intraoperative photos as food as well.
yeah, exactly.
Dining.
So the patient's feet are actually to the right, and the head is to the left. So this is the where my arrow is here, is the innominate. Actually, here's the carotid right here being pulled, and so you can see this is where the right recurrent laryngeal nerve is coming out from under the innominate artery, and so the joint would be up here at the top left corner of the screen. But you see all this sort of white area. This is all tumor here, and so so you see the nerve is much better delineated here, and then it just sort of disappears into this mass where you see this sort of sclerosis here. And you often see that with tumor and also some potential treatment response there. So I guess before I go on, I do go through this, but I guess maybe this is a good point for discussion in terms of you have a medullary thyroid cancer, that looks to be intimately associated with this nerve. It is still stimulating, and the other nerve has been dissected, and the other nerve is fine. This patient has some distant disease. His calcitone is 71,000. So, I guess I pose this to the discussants, and I can sort of share my thoughts as well. But how to manage this nerve in this particular case, I think it's a controversial area, not clear, black and white, and a good point for discussion.
If I would volunteer, I would try to save it. I would argue that this patient is never going to be surgically cured with a calcitone of 70,000. There's going to be disease that's beyond what you can see. That you should try to make your surgery as minimally morbid as possible. In addition, we're in the era of selpercatinib and pralsetinib, and those are just the second generation. What about the third and fourth generation ones that are going to be coming? And people like you, Mark, are pushing the envelope, and with your neoadjuvant studies, you're going to help define how we use this. But what if we find out that after your surgery that there still is going to be continued beneficial effects from continuing with the selpercatinib down the road? What if your selpercatinib keeps that microscopic disease there stable for years, and you wind up with a partially mobile cord there and a good voice in this patient who's not going to be cured anyway? I would argue that's value added. So I would try to dissect it and preserve it, micro dissect it. I would use like these tiny little micro scissors that we use, our plastics micro scissors. Use a lot of epi and pledgets. I don't use any cautery. I use loops or microscope. I go really slow and try to dissect it off. If it's really fused and embedded, then it's different. Then you may have to remove it just to remove the tumor, but I would try to save the nerve if possible. That's unconventional. I think that maybe 10, 15 years ago in the pre first and second generation RET inhibitor era, before the TKIs were showing what they can do, maybe the conventional thing would be just to resect it and medialize the patient.
Those are great points. Well, so I did try to dissect out this nerve, and you can see sort of dissecting it through tumor here. And so no doubt about it, there is going to be some residual tumor cells that are going to be stuck to the perineurium here, but dissected it through the tumor, and it maintained stimulation. So I did continue to dissect that and able to dissect that nerve out, and you can see going up into the joint here. So that was as Dr. Wong suggested, that was the decision. And by the way, this artificial intelligence gave me a picture containing arthropod red invertebrate crayfish. So for what that's worth. But no, here the nerve, that was the decision that we made in terms of in terms of preserving this nerve as well. So the intraoperative sort of strategy and decisions that sort of I was faced with in this case, and this case was only about 2.5 weeks ago, we talked about the recurrent laryngeal nerve. It was functioning by the nerve monitor and some mild weakness maybe on the flexible exam, encased in tumor. And we talked about that. We did dissect that out, leaving sort of this sort of really, to be honest, R2 disease. Not, I wouldn't even call it R1 because I could actually see what looked like probably little tumor specks along the perineurium there. But also, what about the ill-defined and sub-centimeter right retropharyngeal disease that we showed? So I can go back to that picture. And I'm curious from, again, no right or wrong answer to this. But I'm curious in terms of, do we manage this, or do we just actively surveil this? You go from a 1 centimeter to a sub-centimeter retropharyngeal node. I think we've all experienced that, when you're dissecting out retropharyngeal nodes, the smaller they are, the harder they can be to actually dissect because so much of it is by feel if you're doing it transcervically. And then the morbidity of that, of even preserving the hypoglossal nerve, the glossopharyngeal nerve, you're dividing all of those tiny little nerves that go between the pharynx and the vagus. And, there can be some additional dysphagia that patients experience with that. And so just curious in terms of discussants and panelists, how they would manage a situation like this.
Yeah, I would agree with Rich that, the preoperative calcitonin of 71,000 implies typically radiographically identifiable distant metastatic disease. The second issue is prognosis is similarly affected. Even forget about, and you notice Mark didn't present any distant metastatic imaging, so he's keeping that off to the side. And I'm sure at 71,000 there is visible, measurable disease, liver, lung. This is a palliative surgery. So for me, the retropharyngeal node, which has already shrunken to sub-centimeter size, is off the surgical list of endeavors. And I would agree with Rich, but take a slightly different view to what's a palliative surgery relative to right nerve invasion and the contralateral lobe. This is a sporadic 918 disease. He should have unilateral disease. So my take on it would be to be a little bit more aggressive and look at the morphology of the invasive front at the level of the right nerve. And if there was a kind of type A invasion where the nerve was simply abutted by tumor and you could basically get it down to microscopic disease, then I would try and do what Mark did and preserve the nerve. If there was gross disease on the nerve, a type B invasion where the nerve is made ecchymotic and fusiform by infiltration of tumor cells into the substance of the nerve, then I'd say, no, the purpose of this is to remove gross disease. It's going to track along that nerve, maybe go into the larynx. I would be aggressive in that way with that type of morphologic invasive pattern on the right. But similarly, on the left side with unilateral disease, sporadic disease, I might not dissect out the contralateral nerve to obviate so that's really Rich. That's a similar take on a palliative intent as it relates to the nerve. I feel unilateral cord paralysis is well treated. I agree that the dynamic here is and Mark's work has been inspiring in this as it relates to ATC and now RET-altered disease. We've had some experience and we'll be doing some studies on the sister drug to selpercatinib, which is pralsetinib, which similarly gives an amazing partial response rate, where tumor shrinks 30% or more in 2/3 of patients. And it is remarkable. But the different dynamic here is that this patient has metastatic disease and is going to stay on pralsetinib, as Rich was implying. So part of your palliative thoughts have to include that this patient will have enduring selpercatinib effect because she will be kept on that with distant metastatic disease. The other thing I'll just finally mention is that for bulky true mediastinal disease, as Mark's patient has, that has the prognostic significance of distant metastasis for MTC. That's different than cervical disease. This is a whole nother jam. So even if there isn't any radiographically apparent distant metastasis, this patient has a prognosis as if she had liver or lung metastasis. I'm sure she does have liver and lung metastasis, but even if those scans were negative, she's got a bad prognosis.
Those are great, excellent points as always, Dr. Randolph. So we talked about the retropharyngeal disease. We did choose to actively surveil the retropharyngeal disease. We talked about the nerve. We chose to preserve that nerve, leave a little bit of minimal disease adherent to the perineurium. We did maintain stimulation, which was a win for that particular scenario. The superior mediastinal disease we didn't talk about. You know, and this is probably another area of sort of you know, a little bit of controversy, you know, given that this patient has some degree of distant disease, of course, and will sort of need to stay on silvercatinib. You know, do you, I did try to dissect this out transcervically. It was not possible. The inferior extent of this was, that was abutting the innominate vein, you know, kind of right where the innominate veins kind of merge together to go into the subclavian vein, was just not accessible transcervically, and it was really stuck, and so it was not safe to remove that transcervically. So then
let me just ask Mark, because Mark is very humble and he probably won't acknowledge this, but you discussed this all thoroughly with your thoracic surgical colleagues and articulated a plan with them that you would judiciously attempt from transcervical, and then if that was a pushing front, you'd call them and say, go have lunch, I'm all set. And if it was this kind of candle dripping wax into the mediastinum stuck to everything, then you'd call them to discuss it. Is that right?
Absolutely. Yeah, that's a great point. Again, Dr. Randolph. Yeah, so yeah, thoracic surgery, aware, see the patient on standby, just as you outlined. So we did, you know, in this case, I'm curious as to, would anybody choose just to not do the sternotomy and leave the disease if it's not resectable? You know, before I actually say what
I understand your hesitancy for jumping into a different compartment, but I think that mediastinal disease needs palliation as much or more than the cervical disease in terms of, you know, progressive cerebral edema from venous obstruction. You know, it's responded nicely to selpercatinib, but that's, you know, that's a short-lived, nice honeymoon story. And there's going to be problems down the road. So I don't have any, I could argue for and against it, but I think overall the bulk of it, even after its response, would argue that a sternotomy well done would be part of her palliative mediastinal and cervical procedure. Rich, what do you think?
Yeah, I agree. I think there was a lot of bulk in that superior mediastinum, and if it progresses, then you're going to wind up with, you know, compression of the subclavian vein, the subclavian artery was there, even the you know, superior vena cava. So you could have all kinds of compression issues, and that was where the bulk of the disease was. So Mark, I don't think you heard her at all. A sternotomy also is not the end of the world. Patients usually recover really well from sternotomies. I'm not afraid of that at all. It's just that I think that by not going after that RP node, that was smart. That little tiny thing, it's so easy to get distracted and then to spend so much time on this tiny little pebble up in the middle of nowhere. It's so hard to even find that thing, and you're putting all your efforts in the wrong area. The threat is in the superior mediastinum, not that little tiny pebble up in the retropharynx.
Mark,
the other thing is that you could also do external beam there if you ever had to. And we have data showing that is pretty effective at that location. Sorry, go ahead.
Mark, can I ask, when you had everything splayed open mediastinum-wise, was there any entry into any significant vascular structure by thoracics?
We had to shave it off the wall of the innominate. I mean, it was the wall was a little bit abnormal looking. You know, we've all seen these situations. I would call it an R1 resection there. No definite gross tumor, but you're going to get a positive margin, and you know, there certainly could be cells involved in the wall of that vein. We were very thin on wall of the vein. We chose not to do a formal innominate resection and reconstruction just because it was right at the junction of, where the two innominate venous.
Mark, this is maybe you could just mention Mark and I and David Shanka have put together a couple of cases of laryngeal function in patients treated with neoadjuvant therapy. Mark, maybe you just want to describe that, because that's really unintuitive and surprising that would happen.
Yeah, as Dr. Randolph mentioned, I wouldn't say this uniformly happens, but there are some cases where patients do have a traumatic response, where we've documented, Greg and David Shanka and we've documented preoperative nerve paralysis or nerve weakness that has resolved after significant response to neoadjuvant therapy. So again, it's not a uniform occurrence, but it does happen in some cases.
Mark, that's
Can I
a
make
great
a comment?
case. As we move
Just
on to
before
the-
we move on.
Sure, Maisie.
Let me just make a quick comment. One of the things that our thoracic surgeons and I've done with this exact scenario where it's wrapped around the brachiocephalic vein is if it looks like, my neck resection is complete and this is the only disease that left behind is on the brachiocephalic vein, he's actually done a wall resection and have actually put on a pericardial patch on that, and it actually works. So just, something that our thoracic surgeon have done before, if you want to get more complete resection. But anyway, so.
Yeah, absolutely. That's a good option for certain cases as well.
As we move
Mark,
to the
you
very
just
last case,
present the
Mark,
easy cases, Mark? You just present the easy cases to us during this
Well,
panel?
I think
Do you have any
I
difficult
think
cases?
knowing that Greg and Rich were going to be on, I had to present something that at least had a little bit of challenge to it.
Just clear to everyone in the audience that this 918 is a somatic mutation. This is an older patient with tumor alteration, not an inherited germline young patient with medullary.
Great. I think Maisie, you're up.
Okay. All right.
Did Joe have a comment?
there was just a question from the audience there about parathyroids, if you're able to save them all there, Mark, in that case, or how you handled those. That was from the audience.
Yeah, if I remember correctly, I think we definitely saved the superior parathyroids bilaterally. I think we may have implanted one inferior and maybe the other inferior gland we didn't identify. Maybe it was encased in that tumor. So I think we had good parathyroid function. I think identified 3 of the 4 and reimplanted 1. I mean, typically, you know, the superior with most disease, that's the superior gland should be able to be preserved. It's usually the inferior glands that are more at risk with the bulky nodal and extrathyroidal disease inferiorly.
Okay, should I go? I'll kind of rush through this. We're running kind of out of time. So this is a 72-year-old gentleman who was referred to me for recurrent thyroid cancer. His prior treatment was in 2014 at an outside institution. He had a total thyroidectomy, paratracheal lymph node dissection, which appears to be bilateral, and then selective right neck dissection, levels 2, 3, and 4, what was in the op note. They sacrificed the right recurrent laryngeal nerve and they removed 2 parathyroid glands. The final pathology actually was, interestingly enough, staged as T1B and 1B M0. And then the primary tumor was multifocal. On the right side, it was 1.2 centimeters. And then he ended up getting 200 millicuries of radioactive iodine post-op. And his post-treatment scan at that time in 2014 showed no uptake anywhere. So his post-treatment TG was less than 0.4 with a negative antibody. And then a little less than a year after that, his TG kind of remained the same. But at that time, they did an ultrasound and they found a right neck level 4 lymph node, which they did an FNA, which is positive for PTC. And at that time, I saw him. So I did a right completion modified neck dissection, levels 3, 4, and 5. Ended up removing 12 nodes out of that revision neck. 4 were positive. And the largest nodal deposit was 3.5 centimeters. So at that time, which was roughly about a year after his initial radioactive iodine treatment, when I operated him, the largest node was 3.5 centimeters. Now remember, he was radioiodine. There was no uptake in his original radioiodine. So in 2017, his TG bumped a little bit to 0.7 unstimulated. Then he disappeared. He was cared for by an outside endocrinologist and resurfaced in 2021, somewhere in his records. The repeat thyroid globulin was 25, and that's unstimulated. So he was sent back to me, and at that time, his examination showed this mass in the just above the sternal notch. And as expected, he had a right vocal cord paralysis, from his first surgery. So his ultrasound that he came with, and I just want to quickly orient you. This is the trachea, and you can see this mass here. Here's the carotid artery. So there was a retrocarotid node. So this is essentially central neck disease that kind of got out of control. And this is the mass that you can visibly see just above the sternal notch. And here are the straps. So this is still central neck disease. And as we go lower, all I can see was this mass on top of where the innominate and subclavian take off. So I obtained a CT scan because I couldn't get a full assessment of what was going on with the vessels. Here is the mass that you can see on ultrasound, carotid artery. And there's this sort of infiltrative look that really bothered me. And as we go down more imperially, this central node becomes more visible. And you can just see the sort of potential mass just wrapped around the great vessels. And then as you go down lower, this is the actual brachiocephalic vein, or the innominate vein. And there's also disease posterior to it between the trachea and that. Just a coronal view showing just some of this. Here's the subclavian that's taken off here. And it's just potentially infiltrative look. And when I see this, it always worries me with the TG that bumps like this suddenly, that this has become de-differentiated and potentially, possibility of anaplastic thyroid carcinoma. So then I obtained an MRI to better figure out whether or not this is just a bunch of matted nodes, or is there really just sort of, 270 degree, 360 degree encasement of this carotid, because this will make a difference in terms of what we do. And one of the lower cuts was somewhat concerning for that. And our radiologist thought that perhaps there is a plane and that these are multiple matted nodes. So I did rebiopsy him to make sure that this was not anaplastic. And it was not. Finished up his metastatic workup, and there were no pulmonary metastases and abdominal no metastases. And he does have a 4-centimeter aortic aneurysm. The reason I didn't get a PET and got these is because I knew in his medical history that he had an aortic aneurysm, and I wanted to just make sure, for considering surgery, that this thing hasn't gotten bigger, and because this will be one of his comorbidities. That's why I did the chest and abdominal CT rather than a PET CT. All right, so at this point, maybe I should just quickly open up to what the panelists are thinking.
Maisie, what was the biopsy result on the mass, and was
Papillary.
Papillary. Well differentiated papillary?
Yeah, that's what conventional papillary is what our pathologists.
And it was the same. The pretracheal one was the same as the one that was hugging the carotid. They're two different masses, or it's one thing in continuity?
It's two different masses, but they look identical. It's
I
just,
see.
except that on the imaging, it looked like, there may be sort of infiltrative appearance around that carotid, the common carotid, right where it takes off from the subclavian artery.
Well, I agree with your being worried. I'm worried just looking at the images. I think it's good for a surgeon to be worried, by the way. I think it's a good state to be in. We should mainly be worried. If we're not worried, we should be worried that we're not worried. Anyway, I think that the carotid artery is totally legit. And if you and your radiologist with MR or CT or whatever you use can't make a definite decision about it's involved or it isn't involved, then you get a vascular surgeon by your side available. That's number one. Number two, some of this goes down low, and so you got to decide what sort of mediastinal access you need. The thing though, the carotid generally worries me less than recurrent disease in the neck base in a previously operated patient with an indistinct margin to veins. That's more of a problem for me, I think, because you're in scar, you're in scar, you're in scar, and then all of a sudden you're looking at the lumen of the innominate vein. And that, the rubbery tube-like outer wall of the carotid can usually brush you off a little bit more, whereas that vein wall blends with the scar. So it's really the veins that freak me out more. So I get all of the complicated inferior region 4 carotid sandwiching of the nodes, but that central neck node looks like it's indenting, nosing into the innominate vein, as you pointed out, and that would be the thing that I would most discuss with my vascular surgeon or thoracic surgeon.
Okay, so basically, I got a vascular surgery consult. I ended up getting an MRA to look at his cerebral circulation because I need to discuss with him if we are going to do surgery. What are his risk of stroke? And he did have a patent ACOM, and then his right PCA was really nearly codominant supply from the right ICA and the basilar artery. So he does have some, basilar artery contribution. And I also obtained a thoracic surgery consultation just in case we got into trouble with, the potential need for sternotomy for excess for vascular control before it's repaired. So, because I was concerned about the dedifferentiation, the tumor analysis was obtained, which showed a BRAF V600E and a TERT promoter region mutation and a CHEK2 loss. So this is an aggressive tumor. And as we all know, this double mutation has been shown to, behave very aggressively. So I, presented him a tumor board, and we, in a multidisciplinary fashion, we discussed his management options, which would be surgery, non-surgical therapies, such as retreatment with radioactive iodine, external beam radiation, and then the various targeted chemotherapy and possibly even immunotherapy. So these were discussed in a multidisciplinary fashion.
I would just add one other possible consideration is that given the vascular abutment, to treat with a neoadjuvant option could also be considered. But it isn't the one that you would think. The BRAF positivity in anaplastic would make you think about dabrafenib and trametinib plus or minus immunotherapy as a preoperative adjuvant, but that's effective in some cases, as Mark has shown, for ATC, anaplastic carcinoma, but is not effective for differentiated cancer. Right. So this patient, we have a neoadjuvant trial on lenvatinib that will be opening up with Rich and Mark this year. We've enrolled 7 patients. Because lenvatinib is a multiple tyrosine kinase inhibitor, so it doesn't really need a RET or an ALK or an NTRK alteration. It is more agnostic to the NGS testing. So that would likely shrink this tumor to some extent. At least we would discuss that as an option. Mark, what do you think about that?
I think that's a reasonable, reasonable choice, either, using lenvatinib or I agree with you that you typically with the differentiated cancers, you don't see the extent of responses that you see with the BRAF inhibitors, with the BRAF mutated differentiated cancer, as you would see in a poorly differentiated or anaplastic. Yeah, BRAF inhibitor would be another option. And sometimes in these cases, just stable disease is enough, depending on the patient age, and avoiding that surgery for a couple of years can be a good option as well. But I agree with you. The lenvatinib would be an appealing choice potentially as well, to try to shrink the disease as you're showing in your trial.
Yeah, so all those things were discussed. You know, the patient really did not want any external beam radiation after, you know, we discussed some of the side effects. And we deemed this tumor to be radioiodine refractory, just based on the fact that when he probably had a 3-centimeter tumor, it was not taking up any iodine. So it was sort of considered that.
Is he also, you know, your TG back when you did your neck dissection in 2015 was like what, 0.4 basal, and you had a 3.5 centimeter mass. So this is really like not a TG producer,
Right.
not an iodine uptake
Right.
kind of tumor at all.
So not too surprising given the mutations that he has. So after all that and long discussion, the patient really elected to have surgery. We do not have a neoadjuvant protocol for these, and you know, this was something that we had also discussed at tumor board. So anyway, long and short, we had everybody lined up: thoracic surgeon backup, vascular surgeon backup. We did a right revision, lateral and central neck dissection with excision of the subcutaneous tumor of the skin, and then we did a sort of a local SCM rotation flap with the advancement flap to close that skin defect. And the pathology of the pretracheal mass, you know, tumor is present at the superior and deep soft tissue margins. So I think he's got this sort of dermal spread, and that's what it looks like. But the actual skin margins were negative, and there were multiple matted pre and right paratracheal lymph nodes with metastatic PTC, some with extracapsular extension. So yeah, I just wanted to spend a couple minutes just sort of, you know, for the audience, understand that, you know, radioiodine avidity requires the stimulation of the sodium iodine supporter transcription and its expression on the cell surface of these thyrocytes. And the predominant mutations in advanced thyroid tumors are in the components of these pathways, these two pathways here. And so if you have this hyperactive, you know, pathway, then it's going to suppress your sodium iodine supporter transcriptase, and that's what makes these tumors become radioiodine resistant. So, you know, management of these dedifferentiated thyroid cancers, you know, there are multiple options categorically. So your tyrosine kinase inhibitors, you know, a lot of these have just been mentioned by the previous presenter and Greg and Rich. So, you know, the BRAF inhibitors, the MEK inhibitor, you know, that targets all these along this pathways, the mTOR inhibitors, which is, you know, being investigated, and also the immune checkpoint inhibitors are also being investigated. So there are a lot of different options now that are either investigational or clinical trials, or even FDA approved. And understand that some of these do have a lot of side effects, you know, so these need to be discussed with the patient by the oncologist. So, you know, one of the big trials that's often quoted is this selumetinib trial that has been shown to improve their radioactive iodine uptake in these radioiodine refractory differentiated thyroid cancers in a phase 2 trial. But recently, the phase 3 trial showed that the addition of this drug to adjuvant radioactive iodine actually failed to improve the complete response rate for these patients. So it's kind of interesting. But, you know, I think there are other drugs that are in the clinical trial that are investigating this to improve, you know, to turn a radioiodine refractory tumor into a more radioiodine avid tumor. So there's some very exciting, you know, stuff that's being investigated.
Very nice case.
Yeah, it's a great case. Alan Ho and Jim Fagan wrote that New England Journal paper in what I can't believe was 2013, and I think they have found that the RAS-driven tumors tended to be more likely to respond to selumetinib, which is a MEK inhibitor. The idea being that they're going to block the loss of NIS, sodium iodine symporter, and then revert them hopefully back to a more differentiated state. And then New England Journal paper, it was the RAS tumors that responded. And the follow-up study that Alan presented at ASCO was very disappointing. He had worked so hard on it, but we have an active trial ongoing still on this strategy and really limiting it more specifically for RAS-driven tumors. And we certainly have seen some cases where there's been really robust uptake where you do the iodine scan with Gross disease and there's no uptake, and then they get the selumetinib. They're doing other MEK inhibitors now. They're not doing just the selumetinib anymore, but they're doing other combinations. And suddenly you see like this really robust uptake. It's hard to show that leads to like, longer disease-specific survival or anything, but there still is. We still have enthusiasm for this approach, even with that negative ASCO abstract. Thank you.
Okay, well, we've gotten to the top of the hour, and I just want to thank our panelists and our discussants for such a wonderful, rich discussion. I think we could talk for hours longer about these topics, but thank you for joining us this evening. I hope the audience enjoyed as well. Hope everyone has a good night.
Thank you so much for your work,
Thank
Joe
you.
and Marika. Thank you, everybody.
All right,
Thanks,
take care.
Thanks,
Joe and
everybody.
Marika, thank you so much.
Great job. Thank you.